In the ER, we are basically taught to look for patterns, right? But what do you do when a previously healthy 45-year-old guy comes in with a crashing cardiovascular system, a failing liver, and lungs full of emboli? And the only clue you actually have is that he works as a cleaner.
Yeah, that's a terrifying scenario.
Right. So welcome to this deep dive. Our mission for you today is to step right into the shoes of an internal medicine resident on call. We are looking at this multi-system puzzle happening in real time, and we're going to dissect the critical diagnostic steps, the clinical reasoning, and the underlying mechanisms driving the management choices in a really high-stakes case.
Because the emergency department is where your clinical reasoning is tested to its absolute limits.
Yeah.
You rarely get a neatly packaged presentation. You just get these, well, fragments. And with this patient, the timeline of those fragments is our first major clue.
Yeah, let's look at that timeline.
So we have a 45-year-old previously healthy Bangladeshi male. He has a 10-day history of subjective fever, chills, and sweating. I mean, that's a prolonged systemic inflammatory phase. Then it sort of localizes. He develops right upper quadrant abdominal pain, nausea, non-bilious vomiting, and jaundice.
This is a very clear hepatobiliary phase.
Exactly. But then, and this is where it gets weird, 5 days before presenting to the ER, the clinical picture just fractures. He develops a totally new symptom, which is intermittent, diffuse, non-radiating pleuritic chest pain. So we've progressed from systemic to hepatobiliary to a sudden cardiopulmonary phase.
Wow. And, when you look at his review of systems in the initial workup, it's mostly just a wall of negatives, like no headache, no neck stiffness, no cough, no dysuria. And I think in a high-stress, fast-paced environment, it's so tempting to just gloss over a negative ROS to get to the positive findings, right? But what do all of these negative findings actually help us with?
They're actually doing some really heavy lifting. They represent active cognitive narrowing. I mean, when a patient has a 10-day fever and multiple organ systems involved, your differential diagnosis is just incredibly broad.
So you need to start crossing things off.
Right. Establishing that there is no neck stiffness or photophobia, that moves meningitis way down the list. No cough or hemoptysis shifts us away from a primary lobar pneumonia. No dysuria pulls us away from a primary urinary tract source.
Yeah.
You're basically safely shelving certain pathways so you can focus your cognitive bandwidth on the remaining possibilities.
That makes sense. But I actually want to push back on the social history we were given because it feels dangerously incomplete.
Oh, absolutely.
It just notes he works as a cleaner in Saudi Arabia. We had several comments from the medical audience reviewing this case, pointing out how inadequate that is, like what kind of cleaner. If he's using industrial solvents or aerosolized chemicals, that could induce a chemical pneumonitis, right? Which would perfectly explain the sudden pleuritic chest pain.
Yeah, or consider his environment.
Exactly. Another comment pointed out that if he is exposed to sewage water in his line of work, leptospirosis immediately shoots to the top of our differential given the fever, jaundice, and abdominal pain.
You've hit the nail on the head. Connecting his occupational history to a specific microbiological risk profile is crucial here. A cleaner in a sterile hospital ward carries a completely different exposure risk than a cleaner working in, subterranean sewage management.
All right.
You just cannot leave a social history at a job title. It has to be a targeted exposure history to actually narrow the differential.
Right. So based on this detailed history and the active narrowing, we can start to limit our differential diagnosis and make a set of investigations we'd want to order. But first, his physical exam is where the clinical picture really starts deteriorating. He looks ill, he's diaphoretic, and his initial blood pressure is 88/50.
Which is really low.
Yeah, that's a mean arterial pressure, a MAP of just 62. They push a 1-liter normal saline bolus, and he barely responds, improving slightly to 93/67. So, okay, let's unpack this. With a MAP hovering right on the edge of critical organ perfusion, the immediate bedside question is, do you think he is in shock?
Oh, he's definitely in shock. The question is, what kind? You have to determine the mechanism of the shock state at the bedside. Is it a pump failure, a fluid deficit, or a pipeline issue?
And how do you differentiate that quickly?
You do this by assessing peripheral perfusion. Are his extremities warm or cold? The notes here indicate his capillary refill is less than 2 seconds, and his peripheral pulses are intact.
Okay, so his vascular beds are dilated. Warm extremities.
Exactly. Warm, well-perfused extremities in the setting of profound hypotension point directly toward a distributive shock state, like sepsis. The systemic vascular resistance has just plummeted. The blood vessels are dilated, and the blood is pooling in the periphery rather than returning to the heart.
And if they were cold?
If his extremities were cold, clammy, and mottled, we'd be dealing with intense peripheral vasoconstriction. That leans heavily toward valgically or cardiogenic shock, where the heart is just failing to pump blood forward.
But wait, the heart might still be involved here, right? Because his chief complaint included pleuritic chest pain. Yet, looking at the cardiovascular exam in the notes, it just reads S1 and S2 normal, no murmurs.
That sounds like a copied forward template.
That's exactly what I thought. Given the chest pain and the systemic inflammation, is there anything else that might be better organized for the exam? We should be actively hunting for signs of myopericarditis. We need to be specifically auscultating for a pericardial friction rub or distant muffled heart sounds indicating an effusion.
100%. When the history strongly hints at a specific pathology, your physical exam can't just be a passive screening tool. It has to be an active interrogation of that organ system. You have an ill, hypotensive patient with a highly suspicious timeline of RUQ pain followed by pleuritic chest pain. The exam has to reflect that complexity.
Right. Well, with the MAP that low and his microvasculature visibly struggling with tone, his organs are essentially starving for perfusion pressure. And when we review the labs, that starvation is definitely showing up.
Oh, it's a cascading failure across multiple systems.
Let's look at the complete blood count and the coagulation panel. His white blood cells are high at 13.6, which we expect. But what do you think the CBC is pointing toward in addition to that? His platelets are consumed down to 95.7. What are the possible causes of low platelets here?
My immediate thought is disseminated intravascular coagulation, or DIC.
That's a very solid thought.
But wait, his coagulation profile, his PT, PTT, and INR is completely normal. Is DIC even possible in the context of a normal coagulation profile?
Yes, absolutely. DIC is a highly dynamic process, and we are likely just catching it in its early evolution.
Oh, I see.
See, the initial phase of DIC involves widespread endothelial damage, right? That triggers massive platelet aggregation. The platelets act as the physical plug, so they are consumed first to build these countless microthrombi throughout the small vessels. Ah, so they drop first.
Exactly. The actual protein coagulation cascade, which is what your PT and APTT measure, takes longer to deplete its factors. Finding isolated thrombocytopenia with normal coagulation times does not rule out early DIC. It often just tells you exactly where you are on the timeline of the coagulopathy.
That is fascinating. Okay, moving to his renal function. His creatinine is 122 micromoles per liter. Obviously, this is an acute kidney injury, but how do we actually define AKI, and does it fit here?
We use the KDIGO guidelines to define AKI. It's essentially a rise in serum creatinine of at least 0.3 milligrams per deciliter within 48 hours, or a 1.5 times increase from baseline in 7 days, or a significant drop in urine output. And yes, it perfectly fits here.
So what's the mechanism for him?
He's been sweating and vomiting for 10 days, meaning he has a massive absolute fluid deficit. Combine that with the sepsis-induced vasodilation we just discussed. The systemic vascular resistance is so low that the hydrostatic pressure driving blood into the glomerulus drops below the critical threshold.
The kidneys aren't getting squeezed hard enough to filter.
Exactly.
Yeah.
The afferent arterioles in the kidneys are starving. It's a textbook pre-renal AKI driven by severe volume depletion and distributive shock.
And that volume depletion also plays into one of the most interesting paradoxical lab results in this case. His potassium is severely low at 2.98. Initially, it's easy to assume, well, he was vomiting, so he just vomited up his potassium, right? Is that what's happening?
No, actually, that's a huge misconception.
Yeah, we had a really great nephrology comment point this out. Gastric fluid is mostly hydrochloric acid, not massive amounts of potassium, so vomiting actually causes a loss of chloride, leading to metabolic alkalosis.
Right, and the hypokalemia here is a beautiful illustration of compensatory renal physiology. To buffer that alkalosis, his cells pull hydrogen ions out of the intracellular space and into the blood. But to maintain electrical neutrality, they have to push potassium into the cell.
So it's an intracellular shift. The potassium physically leaves the serum.
Exactly. But wait, that's not the only mechanism depleting his potassium. It's a double hit.
Okay, what's the second hit?
The profound volume depletion from the vomiting triggers the renin-angiotensin system. The entire goal of aldosterone is to salvage sodium and water to defend his blood pressure. But it does this at the distal convoluted tubule by exchanging sodium for potassium. So the kidneys are actively dumping whatever potassium is left in his serum into the urine just to hold on to water.
Wow. So it's shifting into the cells A and D being dumped in the urine. That explains the 2.98 perfectly. But here's where it's really alarming. The lab value that sets off all the bells is his procalcitonin. It's 160.57 nanograms per milliliter. What does a number that high actually mean?
Well, normally procalcitonin is a peptide precursor produced in the thyroid, but a level of 160 isn't coming from the thyroid. During a severe bacterial infection, massive release of inflammatory cytokines triggers neuroendocrine cells all over the body, lungs, intestines to just start aggressively synthesizing it.
Right.
A level around 0.25 suggests a localized infection. Once you cross 10, you are looking at severe sepsis or septic shock.
And his is 160.
Yeah. A level of 160 indicates an overwhelming massive bacterial burden. It strongly points to severe sepsis, a very high risk of mortality, and tells us this infection has likely metastasized far beyond its primary source.
Which brings us to the imaging. We need to find that source. His chest X-ray shows cardiomegaly and bilateral congestion in addition to a left middle zone consolidation.
A very messy cardiopulmonary picture.
Right, and his ECG showed sinus tachycardia, low voltage, Q waves in the inferior leads, so 2, 3, and AVF, and a positive R in V1 and V2, which might indicate an old inferior or right ventricle MI.
So we have pulmonary consolidation suggesting an infectious pneumonia alongside congestion and ECG changes pointing toward cardiac ischemia or failure.
Exactly, and because of the jaundice and right upper quadrant pain, they ordered an abdominal ultrasound. But we have to be careful here because it wasn't performed appropriately enough to depend on the results. The patient was in severe respiratory distress, he was uncooperative, so they couldn't do a whole scanning of the liver.
Which means ruling out liver lesions is impossible. You have to repeat it or get a CT.
Well, they tried to order an emergent CT of the abdomen with IV contrast. But a resident commented on this case that the radiologist on call actually rejected the emergency scan.
Oh, that happens more often than you'd think.
Yeah, and it sparked a huge debate among the medical audience on how an internal medicine resident should handle this at, like, 2 a.m. One audience comment said, "You absolutely have to do the CT on call. The patient is septic. You need to communicate with the radiologist, explain your clinical view, and just convince them."
But the counter perspective is purely pragmatic, right?
Yeah.
Think about the immediate management. In the first 24 hours, what actually changes if you get that CT?
Not much, I guess.
Right. The patient is already being aggressively resuscitated. He's getting fluids, broad-spectrum antibiotics like tazocin. Whether the CT shows an abscess or a biliary obstruction, those life-saving orders at 3 a.m. stay the same. Doing the CT in the daytime means you don't delay the patient's admission from the chaotic ED up to the ward or the ICU where he really needs to be.
That makes a lot of sense. But the delay in imaging leaves the team wrestling with these two competing scenarios, a really fascinating chicken or the egg pathophysiological dilemma. Scenario A is that the patient presented with a primary cardiovascular event, like myopericarditis and heart failure, that caused liver congestion and abdominal pain. This would explain the high LFTs.
Yes, the failing right ventricle causes venous blood to back up into the hepatic veins.
Right. Or, scenario B, a primary hepatobiliary infection caused sepsis, which then led to sepsis-induced myocardial dysfunction and secondary heart failure. But wait, the physical exam didn't show typical signs of volume overload, like a distended jugular venous pressure?
That's the trick here. You need volume to distend a vein.
Oh, right.
This patient has been vomiting and sweating for 10 days. His intravascular volume is completely depleted. That profound dehydration perfectly masks classic signs of right-sided heart failure, like a distended JVP. He simply doesn't have the fluid reserve to show us that physical sign, even if his heart is failing.
Wow, so the physical exam can actually be misleading if you don't adjust for his fluid status. So they stabilize him, push the antibiotics, and the daytime CT is finally performed, and the blood cultures come back. The CT reveals a large pyogenic liver abscess and multiple cavitary pulmonary nodules, which are septic emboli, and the blood cultures grow Klebsiella pneumonia.
Okay, that completely shifts our understanding of what we're fighting.
Yeah.
A previously healthy 45-year-old coming in from the community with a massive liver abscess and metastatic spread to the lungs points directly to invasive Klebsiella pneumonia syndrome, or IKPS.
Because normally we think of Klebsiella as a hospital bug, right?
Exactly, an opportunistic hospital-acquired bug. But IKPS is driven by a distinct hypervirulent strain known as hvKP. It's notorious for causing severe multi-organ septic embolization in completely healthy individuals right out in the community. Its hallmark is metastatic tropism. It establishes a primary site, usually the liver, and then just aggressively seeds other organs via the bloodstream.
And because of that aggressive spread, there's a classic triad of extrahepatic sites that you absolutely must screen for. We already found the pulmonary involvement with the nodules on the CT. Second, you have to screen the central nervous system for meningitis. And what's the third one?
The third is the ocular system, and this is highly time-sensitive. Hypervirulent Klebsiella has this terrifying ability to cross the blood-retina barrier, causing endogenous endophthalmitis.
Oh, wow.
Yeah, and it can lead to irreversible blindness within just 24 to 48 hours. It requires an immediate bedside slit lamp examination by an ophthalmologist to try and prevent that blindness, even if the patient isn't complaining about their vision.
That is terrifying. Okay, what about the heart? His baseline transthoracic echocardiogram, a TTE, showed his ejection fraction was mildly reduced to 40%, which supports the sepsis-induced myocardial dysfunction theory we talked about. But there were no vegetations seen on the valves. Should we do a transesophageal echocardiogram, a TE, just to be routinely sure?
The clinical protocol actually advises against a routine TE here. While hvKP is highly metastatic to the lungs, brain, and eyes, native heart valves aren't usually the primary target. A TTE is the standard baseline to evaluate that myocardial depression.
So when would you do a T?
You only escalate to a T for specific high-risk situations, like if the patient has a high-risk cardiac substrate, say a prosthetic valve, or if you're seeing atypical systemic arterial emboli, or if there's persistent bacteremia despite getting source control and being on the right antibiotics.
Let's talk about that source control. The whole management plan pivots here. The patient was switched to meropenem, but medical therapy alone isn't going to fix a massive liver abscess. Does interventional radiology need to do the drainage immediately or after stabilization? And what size of liver abscess even needs drainage?
Usually anything over 3 to 5 centimeters is a candidate for drainage.
Yeah.
But you absolutely have to stabilize the patient first if they're in shock. However, draining a hypervirulent Klebsiella abscess is incredibly challenging because of its hypermucoviscous consistency.
Hypermucoviscous, what does that mean practically?
It means the bacteria produce an incredibly thick, sticky capsule. In the lab, if you touch a colony with a loop and pull it away, it stretches out into this long, stringy filament. It's wildly viscous.
Oh, wow.
Yeah. So inside the liver, this creates a massive, multiloculated abscess filled with this thick, gelatinous pus. It doesn't flow easily through a standard percutaneous drain. You might need multiple large-bore catheters. And incomplete drainage just leads to persistent infection. Plus, depending on the exact location, like if it's high up under the diaphragm, there's a real risk of violating the pleural space and causing a pneumothorax. So stabilization is key, but source control is mandatory.
It's amazing how beautifully the clinical reasoning evolved here. From dissecting a really vague history of a cleaner with RUQ pain to interpreting complex hemodynamics, breaking down lab paradoxes like that volume depletion hypokalemia, and finally identifying a hypervirulent metastatic superbug.
It really highlights why you can't just follow algorithms blindly. You have to understand the physiology.
Absolutely. Well, before we wrap up, I know you had a final thought regarding that hypermucoviscous capsule you mentioned. It's not just a mechanical nightmare for the IR doctors, right?
No, it's far worse than that. It's essentially a biological weapon. That incredibly thick, sticky capsule prevents our immune system's macrophages from engulfing and destroying the bacteria. But here's the really provocative thought I want you to mull over.
Okay, let's hear it.
Right now, hypervirulent Klebsiella is mostly community-acquired. But what happens when these hypervirulent strains fully merge with hospital-acquired, multi-drug-resistant strains? It raises an urgent question about the future of antibiotic tolerance, because inside the acidic, nutrient-starved core of a massive abscess, these bacteria don't just rely on genetic resistance. They can enter a low metabolic stealth mode.
Stealth mode.
Yes, they form what we call spheroplasts, basically cell wall-deficient variants. Drugs like meropenem target cell wall synthesis. But if the bacteria detect the hostile environment of the abscess, they just stop building their cell walls and drop their metabolism to near zero.
Oh my God. So the antibiotics have nothing to target.
Exactly. They just endure our best treatment. So the antibiotic washes right over them. And the moment the treatment stops, they rebuild their walls and the infection comes roaring back. It's a terrifying look at how bacteria survive, not just by fighting back, but by hiding in plain sight.
That is deeply unsettling, but absolutely fascinating. To everyone listening, thank you for stepping into the shoes of the resident with us today. Keep questioning the clinical clues in front of you, and we'll catch you on the next deep dive.